Thank you. Thank you for inviting me to talk about this. The Mitchell Ponseti boots and bars was an absolute game changer when we started having to treat atypical clubfoot. So I just want to go through some of the techniques that we use, both to recognise an atypical foot, strategies for correction, and how to use a Mitchell Ponseti brace effectively. So not all club feet are the same. Anyone who's treated a lot of club feet over the years will know this, but they come in all shapes and sizes, from the beautiful long thin foot on the left hand side of the screen to the short fat stubby foots, the ones in the middle that look like they're never going to correct, and then those that are sort of club shaped feet but don't seem to fit any category that we're aware of. So we need to adapt our technique within the Ponseti method to be able to treat these effectively. The sentinel feature for an atypical clubfoot is the transverse crease, and you can both look and feel for this. If you don't, you'll miss it, but it's a really good clue. And some of the pictures that you see here, particularly the one on the far right, is actually what I would call a primary atypical clubfoot that will, with good skill and knowing what you're feeling underneath, will correct really nicely and actually quite quickly. The other ones are more secondary, and they need slightly different techniques as well. But if you spot this transverse crease early on, all can be well. In these different type of club feet, the medial structures that you see outlined in the bone model in green are slightly less tight than usual. So we're not trying to elongate those as much as we normally would to be able to get the correction of the hind foot that we need before we do the tenotomy. But the posterior and plantar structures are more tight. So the areas in pink are more tight, and so you get the plantar crease, and the hind foot and the equinus feels very difficult to correct. In a primary atypical, you start with the usual manoeuvres. You supinate the forefoot around the head of the talus, line it up with the hind foot, and then when you've done that, you start your abduction manoeuvre. But you don't go to 50 degrees. What you do is you stop when you feel the anterior process of the calcaneum come out from under the head of the talus. And it feels very different from the head of the talus. As you know, the head of the talus is a smooth, round structure, and actually the anterior process is quite pointy. Now, these structures are small, and you need to get used to feeling them, but when you do, it'll transform what you do in terms of treatment of clubfoot, because then all the atypicals will have the great treatment that you give on the normal idiopathic club feet. So that's the key. You want the anterior process of the calcaneum to come out from under the head of the talus. Then you know that it's safe to do your dorsiflexion manoeuvres. At whatever point of abduction that is enough abduction. Now, if you don't notice that, things start to go wrong. And Dr. Ponseti knew this, so we'd had long discussions with him about this, because he realised that as his method spread throughout the world, people were abducting and abducting to a specific abduction angle rather than to the point at which the dorsiflexion manoeuvres were safe because the anterior process was out from under the head of the talus. And what happens then if you push further, push beyond where you need to be, things start to go wrong. So you get a mid-foot break, and then you start seeing a crease on the lateral side of the foot instead of on the medial side. Everything gets a bit sore and painful because you're pushing this foot too far. You'll see the transverse crease, but you'll start to get some pressure areas. And what happens as you continue to abduct the foot, the first ray starts to look short because it's having to come round a lot further. And these skin changes, this redness and purpleness that you sometimes see, are pathognomonic of a foot that's really becoming very unhappy. And that unhappy foot gets swollen, you put a plaster on, and then the swelling goes down and then the plaster slips. And when the foot is in a slip position in the plaster, it becomes uncomfortable. Everyone gets upset, the child's crying, the family are crying, and we need to stop this desperate manoeuvre. And we see it as well if the plastering isn't perfect. So you'll see the picture on the left-hand side of your screen. We've got a huge, big, bulky plaster with bulky padding underneath. You can barely see the foot, and nothing is shaped like the foot or the leg of the child. In the second picture, the plasters are really short and they're really only going just above the knee, so it's very easy to get a slip. And then this is what's lying beneath, these feet with bruised and open areas, and on the far right, what we commonly call the purple banana. And that's not how anybody wants their child's feet to look. That wasn't what they expected when they came to your clinic and said you said the Ponseti method will sort this out for you. So we've got, in the secondary atypical foot, we've got a history of many casts and cast slips. And indeed, I've had a patient come to me with 52 casts for every week of their life in their first year. Sometimes they've had a previous tenotomy. Sometimes that tenotomy is in a slightly odd place or maybe hasn't completely got the correction that you wanted. They may have already been put into the foot abduction brace at some point and failed within it because the foot wasn't the right shape. And then people start to get very worried and they'll talk about surgery, and then the family will get scared. But more than that, you've got a baby who's been consoled with quite a lot of feeding along the way. They're older, they're stronger, they're a little bit chubbier, and they're somewhat upset. And you waft any plaster at them or try and do any manipulation and everything gets worse. So what we do then is we calm everything down. We give them what's called a cast holiday for 2 or 3 weeks. And in fact, a little bit longer is also fine. Very often the family go on holiday in that period, but they'll be able to bath their child. They don't need to be worrying about how to get to the clinic to have all the cast changes, and everyone relaxes a little bit. We ask them in that stage to do a little bit of desensitization. So sometimes within the plaster, the child gets really sensitive to fine touch. And what we want to do is give them some good firm massage, some bubbles in a bubble bath so that they get used to that sensation through their skin again. And it makes them easier to accept manipulation later on. And then when we're ready, we start manipulation gently and with careful attention to detail. We assess the foot carefully, find out where the creases are, what's not in the right place, and gently manoeuvre that foot into a better position. Sometimes even with the best manipulation and the best casting, we still need to plan to be available if that cast slips. And if we know that we've got a history of the cast slipping every couple of days, then you need to have a setup that allows you to be available every couple of days to be able to replace the plaster. If they've had a previous tenotomy, and especially if they're older and just that bit chubbier, we plan to do a tenotomy under a general anaesthetic. And we do it at that key time when we know that it's ready, when the calcaneum is out from under the head of the talus and it's safe to do so. But it means that you've just got one chance to get it right. That's going to be your best chance to get that tenotomy done, for it to be a complete tenotomy, carefully done, and to get a really good cast on post-op. So an asleep child in that situation is often better for everyone. Sometimes after tenotomy, we might need to do one more cast. So if we've not got a good neutral position, at least, if we've not got dorsiflexion to at least 90 degrees and hopefully beyond, one more plaster after the tenotomy, give it 5 to 7 days to get a better position. And I've never regretted doing that. I've always got an improved position. When it comes to fitting the brace, either at 2 or 3 weeks after the surgery, depending on age, and depending on whether that plaster is still slipping, we do some very careful counselling. The child may still slip a little bit in the boot, but if you know you've got a good position, you can manage that, and the family can manage that. So we need to get them good at applying the brace effectively very quickly. And we need to give extra support for that and give them some close supervision so that they know they're doing the right thing and that we're getting the improvement that we want. So if we're looking at the manipulation that we're doing, we're thinking long and thin with the foot. So these are Dr. Ponseti's hands, and you can see that if you've got a transverse crease, you're not just lifting the first ray to correct it, you're lifting the whole of the forefoot to correct the transverse crease. So we're looking carefully at what the deformity is and correcting it with our manipulation. So all those metatarsals are extended and we're getting a good moulded cast around that. So we've not got too much padding, we've got careful cast application. The cast is going high enough on the thigh, really right up into the groin, and you've got good moulding around the thigh as well as around the foot and the calf area. We often try and bend the knee beyond 90 degrees, just so a little bit less likely to kick that off, and the toes are going to be nicely exposed. And again, we're going to be ready to change that plaster if we get any slips. So just looking at some of those manoeuvres, this is just lifting all the metatarsal heads, and you can see how that transverse crease across that short foot is brought into a better position. It's a softer crease, and also manipulating some of that swelling at the distal end of the tibia away so that the foot can be well moulded. When you think you're in a good position, you need to time the tenotomy carefully. So you're going to feel that anterior process. Sometimes on these I do an x-ray. I rarely x-ray babies' feet, but sometimes it's helpful so that you know where you are. You need to feel the hind foot carefully amongst all this swelling, and make sure that everything is corrected and where you need it to be before that tenotomy is done. So this is our last chance for a tenotomy. We're going to cut the whole tendon. It's going to be a decent distance up above the os calcis, remembering that that posterior crease is not guiding you. Very often the posterior crease on the heel is actually over the bone, which is cartilage, and you don't want to cut into that. Number one, it's really bad for the cartilage and doesn't heal, but also you're not going to get an improvement in the range of movement of the ankle by doing that. And again, we're going to have one more change of cast after the tenotomy. And this time you're going to get small but significant improvements. So a foot in some equinus is going to get a small improvement after the tenotomy in the second picture. That well-moulded cast that's gone on post-tenotomy with flexion of the knee beyond 90 degrees. And as you come out of that, a flat foot with a better heel definition that should go nicely into the foot abduction brace. So we're managing some expectations here. We're going to predict the cast slips and plan for them. We're going to make sure that the family have got good transport arrangements in place. When some of these families are coming from a distance, we need to think about whether that's the best for them or whether they're going to need to stay near the hospital for a while. You want your best staff, and you can hold off a little bit. So you don't need to rush into doing this treatment. You need everything around this child perfectly placed so you're going to get your best results. We're going to do a general anaesthetic for the tenotomy. We're going to prepare the parents for a little bit of a slip in the foot abduction brace, but this will get better with time, as long as they replace it when they spot it. But we also can say that they should walk independently at the normal age, and if it's a little bit delayed, that's okay, they're going to catch up. Kind of depends on when you're casting them. We're going to keep the same regime in the boots and bars. So in an older child, they may just be getting along to walking age when you're taking them out of the foot abduction brace full time. And there is a slightly increased risk of recurrence later. Difficult to prove. It depends on how well they do with the boots and bars. As with everything, this is a lot to do with how well they do with the foot abduction brace afterwards. And if they keep to a good regime, they may well still be okay. So when you come to fit the boots and bars, the expectations are a little bit different again. So I've fitted a foot abduction brace on a child with an atypical foot at 8 days post-tenotomy. It's quite noisy, but they did extremely well. Choose a snug size and make extra holes in the strap if their feet are still quite podgy and you need that extra length. Set the angles to match the angle in the last cast. So it won't be at 50 or 60 degrees, it might be at 30 to 40. You want to match that last positioning so that they're comfortable in that. And you can get a little bit more later on. What you can see in this picture is that the heel isn't all the way back into that curve, but it's down on the base, and that's what's important, and that's what you're looking for, and that's what the family are looking for. And if in doubt, add an extra ½ centimetre onto the width of the bar. It'll make them more comfortable, and it'll make them less likely to come out of the boot. So there may still be some slipping. So we do train the family exactly how to put the boots on, and we check them really carefully. And that's the whole team doing that. So they're not just sent across to our orthotist to fit this most difficult fitting, but we do that as clinicians ourselves. And what we see when we do that is that the dorsiflexion improves in the boot in the first few weeks. And that's really nice to see. And because of the softness of this brace, the reciprocal movements of the feet improve the range, which is lovely. So the foot stays in position, but as a child kicks and they extend one foot, they dorsiflex on the other side, and that's really good. So they're doing their own physiotherapy, so we let them do that. So some markings from the strap are normal. The skin, we don't want the skin to break down, but some marking is normal. And you've got the Pringles that can help with that, and you can put a little bit of soft felt behind the tongue on the boot as well. Some swelling distal to that middle strap is normal as well. And the foot may still look a little podgy afterwards, and the family may ask you, and say that the foot doesn't look normal yet. Don't worry. That will settle with time. It settles when they come out of the brace full time, and it settles more when they start more walking, and they'll be amazed at that themselves. So keep to the normal protocols, just review and support more often. So that's 23 hours a day with an hour out for a nighttime bath before they go to bed, setting up that lovely nighttime routine around 6-7 o'clock in the evening so that that's what they get used to. And we don't tend to gradually bring them out into part-time wear, into nights and naps. We go straight to 12 to 14 hours with a nice 12 hours overnight with some extra time in the nap time if we can. So we like them to go into, to have their boots put on around about 6 or 7 o'clock, boots, bar, bottle, bed, down for 12 hours if you can. If they're awake, that's okay, but they leave the boots and bars on, and then some naps during the day, and essentially when they go to their sleep place, so that they always associate their cot with having their boots and bars on. This is about training the child, not about the child training the parents. And support is vital during this time. Often these older children are very clear that they don't want their boots and bars on and will make their family only too aware of it. But this is all about the family knowing better than the baby does and supporting them in making those decisions around keeping the brace on. Essentially, with the right skills and the right tools, you can turn our purple banana into a good shaped foot that's going to last a lifetime. And these are happy feet. And if you have happy feet and a happy child, you'll have a happy family. Thank you.